Thank you. And I'm really impressed by how many people have made it for 9 a.m. on the second day. I'm not sure I've ever made it to that time slot of a conference before. And for everyone who was staying at the Ridges and had the 2 a.m. fire alarm, yeah, just to add to the exhaustion. I didn't evacuate, but anyway. All right, so I'm here to talk to you all about IV fluids, and I think the reason that so many of you are here is because IV fluids transcends all of the subspecialties, really. You know, we've got people here who are paediatric, emergency clinicians. We've got nursing staff. We've got anaesthetists, we've got general paediatricians, and I think everybody here has something to do with IV fluids in kids. So I'm going to tell you, my talk's going to be a bit of a timeline, really. I'm going to take you a little bit through history, what we used to do with IV fluids, what I think we should be doing now, and really where we're looking to go in the next decade or two. All right, before I start, as I start, I want you all just to stop and have a think about a patient. Just think about what you would actually do. So you've got an 18-month-old child, depends on your specialty, they might have appendicitis, they're fasting for surgery, or they might be a pneumonia and they're not eating and drinking and you don't want to do a nasogastric for some reason. What IV fluid are you prescribing? Just have a think about it. How much sodium do you want? How much glucose? How much do you want potassium? How much potassium? We'll have a bit of a talk through that. All right, the other thing that I just want to touch on before I get into the crux is I just want to do one quick definition of when I'm talking about hypotonic fluid versus isotonic fluid. So when I'm talking about hypotonic fluid, I'm talking about a fluid with a sodium concentration less than that of plasma. So less than, plasma's got about 135 to 145 millimoles per litre. And when I'm talking about isotonic fluid, I'm talking about a fluid with a sodium concentration about the same as plasma. A little bugbear of mine is that if you actually look at the fluids on your shelf, they're essentially mislabeled. So 5% glucose and 0.9% saline, which is an isotonic fluid, says hypertonic on it. Because it's hyperosmolar in the bag and there are some TGA regulations that they won't change and it's all a bit crazy, but don't get confused with that. So isotonic, same sodium, same as plasma. The glucose in those sort of concentrations basically don't enter the equation. All right, so let me take you back in time. 1950s, this is the real seminal paper for IV fluid prescribing in kids. So Holliday and Seeger wrote, a paper, and they didn't do any particular study, they just looked at data, and they worked out the fluid rate that we should prescribe for children. It was about 1956. So for those of you who are not using electronic medical records to work out your IV prescribing and are still prescribing old school, the 4-2-1 rule or the 150-20 rule, that came from Holliday and Seeger's paper. It was really important, and we still use their calculations today. But within their paper, and it was about a 10 or 12-page paper. Within their paper, they had one paragraph on what the composition of fluid should be, and they said we don't have enough data. And then they said breast milk has this much sodium and potassium. Adults seem to need this much, so why don't we just say it's this much? And that became the basis of prescribing for the next 50 years. And if we look at what they recommended, so they recommended 2 to 4 millimoles per litre, 2 to 4 millimoles per kilogram per day of sodium, for example. And if you look at the rates that they recommended, they came up with this fluid. So, people converted it to this fluid, which is 4% glucose and what we used to call a fifth saline. So that's got 30 millimoles per litre of sodium in it. That's a lot less than plasma. But again, people prescribed that for about 50 years. All right. So then in the 1990s, case reports started to emerge regarding problems with hypotonic fluid. So 30 millimoles per litre, a lot less sodium than plasma, so hypotonic. So papers started to emerge regarding complications from hypotonic fluid in children. And this, I've put this one up because it's a local case, but there were about 50 cases that popped up over a decade as people started recognising it and saying, yeah, me too, we've had that problem too. So this was, one of the cases in this case report was, horrendous. A 3-year-old boy, scoliosis, came in, had surgery, got given 4% and a fifth at a really reasonable rate, 40 mils per hour, which for his weight was fine. He got a bit of extra glucose with no extra sodium in it at an extra 6 mils per hour. not too much. He was getting 46 mils per hour of a hypotonic fluid. At 42 hours, he had a seizure and died. His sodium was 127, not that low. So what happened to him? All right, so just to take you back into physiology for a moment. So you've got your intravascular, and I'm going to just try and keep this as simple as possible because I know I've done a PhD on this and sometimes people start to go. So you've got the intravascular space, that's the space that, that your fluids are injected into, of course, and you've got your intracellular space. And for the most part, they sit there in a nice little equilibrium with the water sort of keeps the concentrations in a nice balance. If you suddenly, and if you look at this, you've got water as blue, sodium as greenish. So if you suddenly put a dilute fluid into the intravascular space, the water can cross back and forth across the cell membrane really freely. Sodium can, but it takes a bit longer and it's a bit clunkier. But water can go back and forth really freely, and it does that to even up the concentrations. So suddenly you've diluted that intravascular space, and the water realises that the intravascular space is more dilute than the intracellular space. So it travels across, and then the cell expands. And that happens in all of the cells in the body, but it's a big problem in the brain, because in the brain you've got a skull, and you can only swell so much when you've got a skull squashing everything. So the only place for the brain to go is down, and that's called coning, and that is essentially what happens in cerebral edema. This is, just humour me, so this is how I also like to describe the same concept. So if you imagine 2 glasses of cordial, red cordial, and it's got magical glass between, so the water can go back and forth between the cordial to even up the concentrations. If you suddenly dilute one of the cordial glasses, the water will travel across the magical glass to the other cordial glass to even up the concentrations, all right? That's a way to remember it. So the naysayers in the 1990s basically said, okay, yeah, I sort of see where you're coming from, but we've been doing this for 50 years and most kids are fine. I mean, if I gave all of you 2 litres of water to drink, you'd probably all be fine. The problem is that kids, what all of you do is you all just would wee out the extra water. You've got good, nice, functioning kidneys. The problem is sick kids don't necessarily have their kidneys functioning in the same way as we do. And that's due to antidiuretic hormone, ADH. Antidiuretic is exactly what it sounds like. It's an antidiuretic. It means that you hold on to water. Okay, and it's fantastic. It's not SIADH. It's not inappropriate. It's a complete evolutionary mechanism to help survival. So if you were a Flintstone, if you were a caveman, and you had meningitis or you had pneumonia, you had to, number 1, survive that illness, but you also had to survive the dehydration that went with that illness. Okay? So you couldn't go for a walk down to the river and have, a glass of water. So ADH basically evolved so that you wouldn't have to drink as much when you were sick. The problem is us coming along and saying, that kid's not drinking, that kid's not weeing, they must be dehydrated, I better pour some extra fluid into them. We know now that ADH is secreted in basically every time we study ADH in hospitalised children, we find that it's increased. We know that pain can increase ADH. We know that nausea can increase ADH. We know that anxiety can increase ADH. And if you find me a kid in hospital that doesn't have pain or nausea or anxiety, they probably don't need IV fluids. So again, it's really unpredictable. And case reports came up of, there were 2 kids in Canada who had tonsillectomies, and one of them started vomiting at about the 12-hour mark. And rather than recognise that this was cerebral edema, the IV fluid rate got turned up and they died. So tonsillectomy, that's not what we would classically think of as, a big problem from an ADH perspective. All right, so that takes us to the 2000s. So in the 2007, the NHS put out an alert and they said, get rid of 5th saline, get rid of it. And then they said, we're not really sure what else to use, maybe half saline, because, that's got over double as much as 5th saline. Here in Australia, most of us had already changed. This was 2007. At the Children's in Melbourne, we changed in 2003. A lot of places had already changed. But if you think about it, a half saline still had half of the amount of sodium that normal saline has, 0.9% saline, that plasma has. So the mechanism could still occur. So that's where I came into the picture. So in 2006, I was doing a quality and safety job at the Children's Hospital. And we had a cluster of kids who came into intensive care with seizures secondary to hyponatremia with a half saline. And we just went, what's going on? Maybe we should be changing to a fluid with a sodium concentration the same as plasma. But until a few years earlier, that would have been 5 times the amount of sodium that had been given up until a few years earlier. So people were worried. And the other thing is, people were asking this question all around the world. So all of the paediatric hospitals around the world had the same question. And everyone was sort of saying, where's the evidence? All right. So I was getting towards the end of my training and we decided to study this. So we did a large randomised controlled trial, nearly 700 kids, and we randomised them to a half saline or to Plasmolite. And I'll talk to you later about why we chose Plasmolite. We blinded the fluids with these fantastic black bags that looked like oncology fluid and freaked everybody out. And I almost changed my talk to you all today about the difficulties of doing a hospital-wide, every department, every ward, randomised controlled trial in a tertiary hospital for someone like me. I'd done no research, none. I hadn't even done a case report. So suffice to say, needed a lot of enthusiasm, had a lot of naivety, but Freddo Frogs got me a long way in terms of bribery. All right, so what did we find? So we found that we could reduce hyponatremia from nearly 11% to 3.8% by changing the fluid that we use. And this was in all comers. This was surgery, this was Gen Med, this was everyone. People had said to us, yeah, okay, you might reduce hyponatremia, but you're going to cause hypernatremia. You're going to get a high sodium. We found more hypernatremia in the half saline group than in the group with more sodium. Now, it's not statistically significant or anything, but it was just interesting to us. There was definitely no trend towards hypernatremia if you gave more sodium. Severe hyponatremia and severe hypernatremia, we saw much the same. Regarding adverse outcomes, I know that I don't have a whole lot of time, so suffice to say, we thought maybe if you give lots more sodium, a child will get overhydrated. We didn't see that. The seizures one is really interesting to me. So we had more seizures in the group that got less sodium. So I haven't really been able to explain that. All of those were children who had a seizure disorder, so these weren't new seizures. Again, it's not statistically significant. It's hard to know if that is because we didn't have enough numbers. We certainly weren't powered to look at seizures, or whether it was just a number anomaly. We also looked at IV line reinsertion because we thought, with the extra tonicity and with the glucose at the point of insertion, would we tissue more IVs? And we didn't find anything worrying there. So that brings us to today. So we did a large randomised controlled trial, and there have been others. There have been probably now about 12 randomised controlled trials looking at the same questions in different populations. So across the board, we now know that there is good evidence that you should not be using hypotonic fluid. So I'll get to that later. I know that we're coming from a very diverse range of outcomes, range of hospitals. I know that a lot of people have already changed, but if anyone is still using hypotonic fluid, so a fifth saline or a half saline at your hospital, it's time to change. And I'd love you to tweet me. I sent my first tweet on the weekend. I've joined Twitter especially for this conference. So tweet me or old school email me or whatever you need to do. Get in contact with me and I'll help you advocate for change within your hospital. The other things that you need to do is consider the fluid volume that you're giving to patients. So the whole old, 150-20 rule or 4-2-1, the standard maintenance rates that we've always prescribed, don't take into account the fact that sick kids probably need less fluid than well kids. So it doesn't take into account the antidiuretic hormone. The other thing to keep in mind when you're talking about fluid intake is the total fluid intake. Okay, so if you're prescribing, I want them to have Plasmolite 148 and 5% glucose at 40 mils per hour, but then I also want them to have some acyclovir and some ceftriaxone and some Fluclox. And then they're starting to improve, so they're drinking as well. You need to make sure that whoever's at the bedside, so your nursing staff's usually at the bedside, are empowered to turn down that fluid rate to account for all of the other fluid that they get with other things. So with their IVs, with their IV antis, with their antiviral, and for the fact that they're drinking. So we shouldn't be thinking about the rate of a specific fluid, we should be thinking about total fluid intake. And in Victoria, we're about to redesign the fluid balance charts across the state so that we'll hopefully have help people to do that. The other thing that we should all be doing at the moment is monitoring kids on IV fluid, okay? That means going to see them when they haven't weed, or they, haven't had anything to drink. Don't just give a fluid bolus over the phone. That means checking a blood test even though you don't want to. That means weighing the patient. We really need to respect IV fluids. And the future. So there's still a major question as far as I'm concerned, and that's whether we should use a balanced fluid like Plasmolite or whether we should be using a fluid like 0.9% saline. And there's a few things to take into account. So the first is, what's the difference? To me, the most significant difference between these two fluids is the chloride concentration. So plasma's got around about 100 millimoles per litre of chloride. Normal saline's got a lot. It's got 154. Plasmolite's got 98, so it's a lot. It's in keeping with plasma. If you can imagine a kid with gastro, for example, so they're vomiting, they've got diarrhoea, they're probably losing a bit of potassium, so you add an extra 20 millimoles per litre of potassium chloride to that bag, then you've got 174 millimoles per litre of chloride. So it's a huge chloride load. So what's the problem with that? The problem with that is a hyperchloremic acidosis. So if you give too much chloride, you can get a hyperchloremic acidosis. What's the problem with that? Well, that's the question that we don't really know. There is growing evidence, a large amount of evidence, but not good, robust evidence, that a hyperchloremic acidosis isn't great. It probably reduces renal perfusion, gastric perfusion. There have been some studies suggesting that it might increase morbidity or mortality, but they're all, in my opinion, they're all quite flawed studies. They're very large, sort of data mining studies. There are studies, for example, of, this hospital uses Plasmolite, this hospital uses saline, this hospital's got a better mortality than this hospital. That's confounded by so many factors. There are some better quality studies that suggest that this is a real phenomenon. Unfortunately, or fortunately, because, we're not biased in research, there was a large randomised controlled trial in adult ICU patients that showed no significant difference. Again, not the most perfect study in that the volumes they got were quite low overall, but it's hard to know. It's definitely a watch this space. But what I would say to you is that if you've got a child with, for example, gastro, and you're pouring fluid into them with some extra potassium, and you look at their bloods and you say, oh my gosh, they're still really acidotic. Actually, they're more acidotic than when they came in. Maybe my clinical assessment wasn't right and they're sicker than I thought. Let's give them a fluid bolus. That's not the right thing to do. So just consider hyperchloremic acidosis as a differential. So ideal isotonic fluid of the future. Well, we can consider balanced versus 0.9. We need to take into consideration with or without potassium. I would like all of your hospitals to be ordering fluids that come with pre-inserted potassium. I hate the idea of people adding potassium on the ward. It's very dangerous. That's if a patient even needs potassium. Probably a topic for another talk, but I'm happy to go into detail about that if you want to. Availability in 500 versus litre bags. Some places want to use smaller bags for smaller children. Compatible with medication. That's been a little bit of a tricky point with Plasmolite 148. There's not as much data about compatibility as there is with 0.9. And cost, because we obviously have limited resources. Quick tangent, cost for IV fluids in paediatrics in Australia is so frustrating because every state, hopefully until recently, I think we're becoming more and more aligned, but every state has been doing things differently. So, it used to be that in one state people were getting 2.5% glucose with half saline or normal saline, 0.9% saline, and with or without potassium in 500 mils or litre bags. So just from an economy of scale perspective, IV fluids in paediatrics cost our hospitals a fortune because we all have these little niche things. If we could get consensus around the country, the price for everybody would go down, but we haven't actually got to that point quite yet. So what do I want you to take home? Throw hypotonic fluid in the bin. fifth or half. There is very, very, very rarely an indication for hypotonic fluid, maybe the occasional renal patient. Consider hypochloremic acidosis when you're using 0.9. Monitor kids on IV fluids, weigh them, do bloods, get a clinical review. And I haven't really talked about this very much, but my final point is to look for evidence. Okay, be curious. So 4% and a fifth was used for 50 years. It was the correct answer on my medical school paediatric exam, but it wasn't the right answer. You've got to keep asking questions, and we've got to really support paediatric research. Thank you.
Thank you, Sarah. That was a fantastic talk, and just such an important topic, given that fluids are given to nearly every single person. Amy, how are we going? There was quite a bit of activity.
Yes, we've had a lot of participation from the Twitter audience, so thank you very much for all your support. There was an interesting observation. Hello, my name is Deanne, has made a few interesting tweets. Thank you for your tweets. She mentioned about your imposter syndrome story, and her take-home message was not to crap your pants, so that's important. And she also loves your shoes. So the talk is amazing, but the shoes are even better. So that's always a win. We've got a few questions. Nikki, is it Abella, yes, asks why do you think children seem so much more sensitive to IV fluid administration?
That's a great question. I don't know that they are. I think that the research in adults is far behind the research in kids. And it wouldn't surprise me that if we did similar research in adults, we'd find not dissimilar findings. I think it's probably under-recognised. I don't know that for a fact. There are other theories about the ratio, the skull-to-brain ratio in kids, that it's that affects it, that it's different to an adult. So in adult, you've got a little bit more room to move. But I go against the research in this. I've never been convinced that that is the main effect. And I actually think, don't get me wrong, this is rare. Hyponatremic encephalopathies are really, really rare. But, and they probably happen rarely in adults as well. There's lots of, where the research is good in adults, sorry, you got me started now, is, so there's evidence in stuff like there was an adult who went into a drinking competition in America. So it was a radio station who could drink the most water would win thousands of dollars, and a woman died in that competition. Wow. So there is evidence. There's a lot of evidence in sports people in adults. So they did a great study on the Kokoda Trail, looking at sodium concentrations. Because you know how maybe 5 years ago, maybe a bit longer ago, a lot of people were dying on the Kokoda Trail, and then some clever people went and checked the sodiums of everyone walking the Kokoda Trail, and they think they were probably drinking too much water and exerting themselves, and the exertion was leading to increased ADH secretion. And they've really changed instructions for athletes on the basis of that. In hospitalised patients, I'm sure that they have the same issues. Rarely, but still the same issues.
We've got a couple more questions. Diana was wondering, what is your definition of hyponatremia and severe hyponatremia?
Yeah, so in the study, and we took a surprising long time to come up with this. So in the study, our definition for hyponatremia was less than 135 millimoles per litre, but it had to have dropped by 3 compared with baseline, because we wanted to make it meaningful. I mean, you couldn't come in with a sodium of 131 and then have a sodium at follow-up of 134 and have that considered to be hyponatremia when that was actually an improvement. So you had to have dropped by 3 compared with baseline. And for severe, we said less than 130, similarly with a drop of 3.
Right,
yeah.
Okay. Zach from Tamworth wonders, should we be using the 4-2-1 rule and times it by 2/3?
Yeah.
Do you think?
Yes, is the short answer. For most kids, I think. I think for most kids, start at 2/3 and reevaluate them. I mean, that's the thing. You should go back and see kids. And you should go back and see them relatively soon. So one thing that we found in our study, we did bloods at 6 hours and then every 24 hours. And we found that most of the hyponatremia had happened within 6 hours. And certainly of the case reports that were happening, I don't know if it's most, but many of the deaths were happening within 24 hours. So if you were waiting 24 hours for a daily blood or a daily assessment, then you're probably leaving it too late. It's hard to know, there's not great evidence for when the blood test should be, but at least a clinical evaluation. And if the clinical situation changes, if you've got a child that suddenly starts vomiting or has a headache or says they're drowsy or has a seizure, check their bloods.
Yeah, that's really important. And maybe just one more. Nicole was wondering, how common is APO or other signs of hypovolemia in children?
APO, as in
like getting too much sort of fluid resuscitation.
Too much fluid resuscitation. Yeah, not very common, I think, is the main thing. I mean, that's a topic for a whole nother talk, is fluid resuscitation, and particularly in the context of the FEAST trial, which was a trial done in developing countries looking at fluid resuscitation, which found that too much fluid resuscitation, well, not too much, that fluid resuscitation could increase mortality. Probably a conversation for a whole other day, but I think we do need, I'm not convinced that those results are translatable to Australia. I do think we have to be careful with fluid resuscitation. I think we can still give 20 mils per kilo when it's needed, but we need to, again, reevaluate and look out for signs of respiratory problems.
Unfortunately, we've run out of time. I think lots of people will probably be keen to catch up with Sarah in the break. But thank you very much, Sarah, for a wonderful opening to our day 2.